Welcome, everybody. Thanks so much for joining us tonight. My name is Rachel, and I'm the Director of Learning and Support Services with Alzheimer Calgary. And on behalf of Alzheimer Calgary, I'm so delighted to have you here. It's our first in-person event since January 2020, which is very exciting. And you will probably notice that people will continue to trickle in. As you probably know, traffic is a bit of a nightmare. And so if folks are trickling in, just if you can find room for them, that is fantastic. Today, I also have a number of staff members with me. I have Samantha Ray and Cindy Bond. Sorry about the feedback. Closer. I'm supposed to get closer. That's not something you've heard a lot probably in the last 2.5 years. So if you notice at the back of the room, I've got Cindy Bond and Samantha Ray. They are part of the wonderful Learning and Support Services team, and they're going to be here to answer some questions and to help facilitate the evening as well. So before we dive into anything, I just want to acknowledge that we are on Treaty 7 land. I'd like to offer gratitude and respect for these lands and honor to all treaty peoples, both Indigenous and non-Indigenous, alongside our animal friends and Mother Earth. We work and reside in Mohkinstsis, Calgary, where the Bow and Elbow rivers meet. We are on Treaty 7 lands, which are the homeland of the Blackfoot Confederacy, which is comprised of the Siksika, Piikani, Kainai First Nations, Tsuut'ina First Nation, and the Stoney Nakoda, which includes the Chiniki, Bearspaw, and Wesley First Nations. Treaty 7 lands are also the homeland of the Métis Nation of Alberta, Region 3. We are all treaty people and deserve these opportunities to move forwards to unity, truth, and reconciliation. Then we can begin to move to Miwok to Siwin, which is the good life. Just a little bit about housekeeping. There are some emergency exits. They are here. They are at the back of the room. There's lots of exits, just so you know. We do have evaluations, so please fill out your evaluations. We have almost enough pens. A few of you may have to share with the neighbors, my apologies. And if you could just leave either your evaluations on the chair or hand them to a staff member or a volunteer, basically anyone with a name tag at the end, we'd be happy to grab them from you because they help us do better. Another very important fact is the washrooms are just outside those back doors. We are going to have 2 microphones at the end of the presentation for questions. There's one right here and one right there. If you have mobility issues and would like to ask a question, raise your hand and one of us will come and actually grab your question from you. Please try to avoid personal information and keep your questions as general as possible. We have a large group of folks here today and we will be focusing on questions relevant to the presentation. For the questions we can't answer, we'll do our best to follow up within a week. And you may have noticed that the Calgary Tower has been lit purple for the last little while. This is in honor of World Alzheimer's Day. A little bit about, we at Alzheimer Calgary, we're dedicated to increasing the awareness and understanding of dementia and reducing stigma towards dementia. We want to provide information about resources and support available to individuals living with dementia and their caregivers. So tonight, we're going to focus on the journey of dementia in its early stages, including the early warning signs and what life may look like after a diagnosis. Whatever the reason you are joining us today, this is a chance to learn more and get connected. We also just want to highlight a few new dementia numbers released from a report from the Alzheimer's Society of Canada. So in Canada, over 600,000 people right now are living with dementia, and by 2030, we expect this number to reach close to 1 million. Alberta is one of the provinces, actually I believe it is the province that is expected to experience the largest percentage of increase in dementia and care partners. Alberta will see a 286% increase in the number of people living with dementia from 2020 to 2050. And caregivers, there's probably a lot of caregivers in this room that are impacted by dementia. For every person living with dementia, a caregiver will spend an average of 26 hours a week caring for them. That's probably not a number that surprises most of you. However, Alberta is expecting to see a 290% increase in the number of caregivers and a 302% increase in the number of unpaid caregiving hours from 2022 to 2050, which means we need to provide support for caregivers. have questions about dementia, if you are a person living with dementia or if you're a caregiver, we're here for you. And we're going to be highlighting some of the resources and supports from Alzheimer Calgary at the end of the presentation. Just a few more things I just want to highlight. We have our upcoming walk and run on Thanksgiving Sunday. Feel free to register or volunteer for the event. I want to thank our sponsors as well. So you may notice that Amica Britannia has a booth out back, so feel free to visit them. Thank you to them. Thank you to the United Way Calgary and area and the Alberta Retired Teachers Charitable Association. So enough of me talking, now we get to listen to someone who knows a lot. Dr. Eric Smith, I'd like to announce his presence here with great pleasure. He's a professor of neurology, radiology, and community health services at the University of Calgary. And he's the holder of the endowed Kathy Taylor Chair in Vascular Dementia. I know you have to wait and hear all of the wonderful things about you before you're allowed to speak. He's the medical director of the Cognitive Neurosciences Clinic and a member of the Calgary Stroke Program. He directs the Clinical and Research Fellowship Program in Cognitive Neurosciences. He graduated from McGill University, trained in neurology and teaching hospitals of Harvard Medical School, and was assistant professor of neurology at Harvard University before being recruited to Calgary in 2008. He co-chairs the Canadian Stroke Best Practices Advisory Committee of the Heart and Stroke Foundation and is a member of the Executive Committee of the Canadian Consensus Conference on the Diagnosis and Treatment of Dementia. His research team investigates how cerebral small vessel diseases cause cognitive impairment and dementia. So thank you so much for joining us, Dr. Smith.
Thank you so much, and thanks for the nice introduction, Rachel. It's a pleasure to be here.
I'm just going to adjust you a little bit.
Hopefully you can hear me okay. It's a pleasure to be here in person with you today after so long with the pandemic, being online and on Zoom and other platforms. And so it's just fantastic to see faces up close and together. So I was asked to talk about warning signs and early diagnosis. I'm a physician. I see patients with cognitive concerns and early signs of dementia in my clinic. So I'm bringing my perspective on what I've learned from my patients and also kind of a physician approach to what we make of symptoms and how we might investigate them, make a diagnosis, and then some of the early considerations on the part of patients and clinicians, when we make a diagnosis and thinking about, well, what are the next steps, what happens next. I'm going to see if I can move my slides here. Oh, I can, okay. And so I'm going to be craning my neck to remind myself of the points that I don't want to miss on my slides, but I'll try to make sure I'm speaking into the microphone. So these are just a little bit about me and what we call our disclosures, right? So I've done some consulting for a company called Eli Lilly that is trying to develop treatments for dementia. And I advise them on a specific condition called cerebral amyloid angiopathy that can complicate these treatments. And for that, they paid me for this consultation. And one of the things we do at the clinic is we offer people opportunities to participate in clinical trials. We run tests of experimental medicines and therapies. The university is paid money to do this, so we can hire a nurse like to do the assessments and this kind of thing, but I don't make any personal funds from these kind of trials. We do them because we think it's important for people to have access to potential new therapies, and we know our current therapies are not enough really to help people fully with the conditions that cause dementia, so we're looking for opportunities to develop new, better treatments. So I'll talk a little bit about terms, right? Like, so what dementia, what does that term mean to me as a physician? How do physicians use that term? How does that differ from Alzheimer's disease? Like, what's the difference between Alzheimer's disease and dementia? I'll talk about some of the early signs that something may be wrong that might prompt you to go to your family doctor or prompt your loved one to go to their doctor to get checked out. And one of the challenges we face as doctors is nobody's memory is perfect, right? Like, we all forget things at any age. And so it's hard to know sometimes, like, when should I be worried and how much should I be worried about different experiences that I've had. I'll talk about it like a doctor's approach to dementia, including like what tests we might order, what kind of questions we might ask about how we would break the news about a diagnosis, and kind of what the best practices are to support people when they're getting a diagnosis about something that could be very scary, right, and life-changing. And then after the diagnosis, then kind of what are some of the first steps you might think about, or how you might think about how the patient deal with this and move on into the dementia journey and understand how to cope with a full life with the diagnosis. Okay, so dementia from a medical standpoint refers to the symptoms. And so these are symptoms of a cognitive decline, like memory or concentration or other aspects of thinking have declined from what they were before. And to an extent where it's interfering with someone's ability to do the daily things they need to do to kind of live independently without help of others. In the early stages, the symptoms might be trouble with more complex activities like cooking or doing complex finances, doing taxes, maintaining the house. Over time, it involves more basic activities, right? Like even in the more advanced stages, difficulties with understanding how to get dressed, kind of eating and toileting, hygiene, taking care of oneself. These things can all be affected by dementia. There's another term that we use when we diagnose a patient where we find there's objective evidence of memory problems, like we do a memory test and there's a poor score, and the person has a concern, but they're still functioning okay in daily life, right? There's a concern, and the memory's not good, but they're still doing the things they used to do. Maybe it's a little bit harder, but they can still do the finances and the shopping. The spouse could go away for a month and they can take care of themselves. This situation where there's objective evidence of impairment, but not to the degree that it interferes with independent living, is called mild cognitive impairment, or MCI. And mild part is not meant to be dismissive of the person's concerns or the fact that they've caused a change in their life, but just that compared to dementia, where the cognitive change is enough to interfere with daily activities, in mild cognitive impairment, the person can still function. But that's a scenario where we want to be able to make that diagnosis of mild cognitive impairment, because we'll do some tests and ask some questions to understand what might be contributing to it. And then people with mild cognitive impairment, on average, there's a risk that it may not stop there. Like it might get worse and go on to dementia. That's often kind of the question people are coming to me. Like, I know it's harder to do these things. Could this be the early stage of dementia? Could I have dementia in 2 years or 3 years? So we're trying to address that question and answer that question as best we can for people. And then Alzheimer's disease often gets kind of conflated with this term dementia because it's the most common cause of dementia. But the difference between the two is that dementia are the symptoms, and then Alzheimer's disease is the cause of the symptoms. So for example, you take another medical symptom like a cough. If I have a cough, it could be a bunch of different things, right? It could be, God forbid, it could be COVID, right? But it could also be asthma or postnasal drip, right? Or something else, right? So there are different causes of coughs, just like cough, dementia has different causes as well. But Alzheimer's disease is the most common cause, so often you hear them talked about at the same time or even kind of mixed up with each other. But from a medical standpoint, to be precise, Alzheimer's is one, but not the only cause of dementia. We define Alzheimer's disease based on the presence of these microscopic features called plaques and tangles. And the plaques are found outside the cell, and they're aggregates of a protein called beta amyloid. And then the tangles, and the plaques are shown in the slide on the left. And the tangles on the right side are found inside the brain cells, and they're accumulations of a protein called tau. And the tau is a protein that normally forms part of the skeleton of the cell, or like a scaffold of the cell on which the cell membrane hangs. It gives the structure to the cell. When the cell is sick, then the scaffold starts breaking down, and you get the bits of the scaffold aggregated into like a little junk pile called the tangle. So when we see plaques and tangles under a microscope, we say, oh, that was Alzheimer's disease. I'll come back to this later, but we struggle to be able to precisely identify plaques and tangles in living people. Right now, the only way to know for sure is to look under the microscope at the brain, but you can't do that while you're still using the brain. We don't do brain biopsies to make a diagnosis. That's a very basic procedure. So we infer the presence of Alzheimer's disease based on a pattern of problems and the results of the other tests. So I'll kind of come back to that later. There are other causes of dementia too. In addition to Alzheimer's, the second most common cause would be vascular dementia. So that's where the dementia is due to blood flow problems to the brain, or sometimes a history of strokes. The third most common cause of dementia is called Lewy body dementia. And that shares some overlap in symptoms with Parkinson's disease. And another cause of dementia that are less common, but we still see in the clinic all the time, would be frontotemporal dementia, or FTD, normal pressure hydrocephalus, or NPH, and there's kind of a list of other things. But 80 to 90% of all the dementia in our community is caused by either Alzheimer's disease or vascular dementia, or unfortunately there's no rule that you're only allowed to have one thing at a time. So a lot of people have some of both. They have both some changes in the brain from changes in blood flow with aging and the vascular component, but they also have Alzheimer's disease. We sometimes call that mixed dementia, when we have Alzheimer's disease and other causes like vascular at the same time. So if there's a memory or cognitive concern, this is one of the things the doctor is thinking about in terms of making a diagnosis, like which of these things may be causing the dementia in those contributors. So again, the idea is that there's a brain disease, like Alzheimer's disease or vascular disease, that causes damage to the brain. And we see, for example, Alzheimer's disease, that the brain kind of shrinks over time, like it loses brain cells, it gets smaller. With vascular disease, we might see strokes or other things that we can see on brain MRI scans, like leaking of blood when it bleeds. And then this damages the brain, prevents it from functioning properly, and then you get the symptoms of dementia, the memory. A pie chart showing the causes of dementia based on a study out of a clinic, and you can see the biggest piece of the pie is actually a combination of Alzheimer's disease and vascular disease. And then kind of more pure Alzheimer's disease would be the next most common, and then other conditions. Okay, so that's kind of the medical paradigm of how we think of dementia, where there's symptoms, and then we're looking for causes. We're looking for other contributors or other causes besides these things too. But what are the kind of symptoms, that people that I hear about in the clinic or that people notice and respond to? So symptoms of dementia include forgetting things, so they could be forgetting about an appointment coming up or an appointment you just had. It includes difficulty with planning and organizing things. It can include difficulty with kind of memorizing and following instructions, like a new iPhone or a tablet or something like that. And it can come with changes in personality and behavior as well. This is something that I think we underappreciated in the past, right? Like in some people you find that, someone who's very active, maybe now they're kind of more passive, right? There's not the mental energy to get up and do things that they used to enjoy. In some people it can be changes in, kind of ability to cope with frustrations. People get angry more easily or get frustrated with problems. And other times it can be related to people's kind of ability to work with others socially, and follow kind of societal norms around social behaviors. People might be overly familiar with strangers, right, when they weren't before. Or even kind of, lose that filter a little bit, kind of blurt things out, right? These are less common symptoms. We do see them sometimes, and people may have other unusual phenomena that they experience, or that aren't really there even, right? Like hallucination, right? Like seeing little people around, doing things, for example, and that they aren't really there. Or getting kind of unusual ideas, kind of like fixed ideas about something. It's not true, but they don't recognize it, and you can't shake them off. And, we see sometimes these type of symptoms can happen too, even in the early stages. As I mentioned, the problem with a lot of these symptoms is that, or especially for the latter ones about kind of hallucinating, I've kind of experienced all those things before. Like, have I gotten angry and been sharp with someone? Yeah. Have I forgotten an appointment? Not today, thankfully, but yeah, I have, right? Do I get confused with my taxes sometimes? Yeah, I do. So where, you know, kind of where's that threshold between what's kind of normal concern for just being a human, you know, and part of human nature, the human condition, versus the kind of concern that may lead, you know, may indicate you're on the path to, and maybe other conditions that can cause dementia. This is a challenge for like doctors as well as patients, right? And I'll explain later some of the ways that we might try to separate, you know, which sort of path people are on. But it remains difficult, and sometimes we need some time too, right? Sometimes like time will tell. We can't necessarily make a diagnosis right there the first time we meet. We have to agree, well, let's check again in 6 months, or let's check again in 12 months, right? And see if things have changed for the better or for worse, and that may give us clues as to what's going on. Again, these are some of the challenges. Like everybody forgets things. And there is evidence it becomes more common as you get older too, right? So on average, you know, if we do cognitive tests, you know, tests could include that I read out a long list of words, right? You try to remember all the words, and then I ask you how many you can repeat, and then later on I ask you how many you remembered. We see that younger people tend to learn the words more quickly and remember more of them afterward compared to older people. So we know on average, you know, there is a change over the lifespan. And people are very attuned to their mind and how it works, may be picking up on some of these age-related changes, right? So that may be a reason why someone has noticed a real change, like undoubtedly, but it's not a disease-related change, right? It's part of their own aging process. We have to acknowledge that, help them like cope with it, but it's not, in that case, in this scenario, it may not be Alzheimer's disease or a disease like that, right? So it's kind of good news and bad news. It's not Alzheimer's, it's you're getting older, right? You know, kind of thing. Now I always tell people though that getting older is not, there are things that improve as you get older too. Like let's be clear about that too. It's what people call crystallized intelligence, right? The kind of intelligence that comes from learning and knowing and having wisdom, right? So, and I can see these differences in my teenage daughters compared to me too, right? They think very quickly, so they're able to come to a bad decision much more quickly than I would be able to. So that's some of the benefit of getting older, but you know, but there are changes, of course. Some people notice them. It also means it's not wrong to worry about your memory too, right? Like worrying about your memory is not abnormal. I mean, why shouldn't someone worry about their memory? Like there's many things to worry about. This is a legitimate cause for worry. So we have to acknowledge that as well, that it's normal to sometimes have some of these concerns, like, oh boy, you know, am I losing it here kind of thing. So, and there are things other than these diseases like Alzheimer's that can cause memory problems. So that's part of what we're screening for when we see someone too, right? There's a lot of, and these things we ask people to reflect on include psychological stresses, right? If you are like chronically stressed out, I mean, the brain's an amazing thing, right? That we can think and reason and do all these things, but as there's limited potential in everyone's brain. And if your brain resources are spent on fretting and worrying and stress, there's just less room to focus, learn and remember other things, right? So we know psychological stress is a factor. Sometimes these come along with mental health problems too, like clinical anxiety or depression. Chronic pain or symptoms from other chronic medical illnesses too, I think are an underappreciated cause of difficulty with concentration and learning and memory. If you're in constant pain from your back, it's hard to concentrate, it's hard to remember. One thing I should put on the slide, I didn't put there also, there's a lot of interest recently in kind of our sensorium and how it relates to risk for cognitive decline, right? By that I mean hearing and vision, right? And so if you have trouble hearing things, we know there's a strong correlation between poor hearing and poor memory. So one of the things we ask people about is hearing. We may ask them to, you know, get a hearing acuity test and maybe try hearing aids. And then not all my patients, you know, like wearing the hearing aids, although I think they're getting better, and sometimes they're cost barriers too. Whatever we can do to help people hear better and see better often puts them in better contact with their environment and makes their mind sharper, essentially. We'll ask about medications, right? There are a number of medications that can dull memory. And maybe we can make improvement by reducing those medications to the least dose that's necessary to have its effect, or maybe some of them even weren't so needed, and we can simplify the medications and help sharpen people's memory. That includes like recreational drugs too, so that's something else to ask about. And as I said, chronic pain and other things. So the sleep might be another one that I would put on there. If you're not getting restful sleep from a condition like sleep apnea, your brain's not fully awake during the day, and you're not going to be able to concentrate or remember. So that's another thing that we would ask about. And then when I hear about these symptoms, it's hard to discriminate these kind of age-related symptoms that are real but not due to disease from the disease-related symptoms. But I think mostly from my experience, I guess, there are some kind of rough rules that are not hard and fast rules. But there are some sets of symptoms that when I hear them, I think, okay, well, this is something we need to look into. But I'm less worried about Alzheimer's disease here. I'm not zero worried, of course, but maybe I'm less worried, and others where I'm more worried. And so this is my kind of spectrum of less serious to more serious. It is well documented that like forgetting names of people and less common objects, this is one of these things that gets harder as you get older. So you see that kind of like, I know that person, and it's going to be embarrassing because I'm supposed to know them, and I know that, and they know that, but I don't remember their name. This kind of phenomenon does happen more frequently as one gets older. The kind of the why am I here moment is fairly reassuring as long as it kind of comes back to you. By that I mean the moment where I'm in the basement and I know I was upstairs and I know I came down here for some reason. There's tools around here, but which one and why, and I just don't know. Often it'll come back to you. It's more reassuring. It comes back to you in a few seconds. Sometimes for me it just doesn't. I'm like, oh, I'm going to do something else. If you're making mistakes, but you recognize the mistakes, you can correct them. That's generally more reassuring than making a mistake and having someone else tell you made a mistake because you're oblivious, right? So, and in fact, even when we were doing cognitive testing in the clinic, you're sort of allowed a mulligan, right? If we instruct you to do a task and you make, oh, wait a minute, no, I was supposed to do that. It's like, okay, we don't count that as a mistake even formally in the neuropsychological testing. So you're allowed to make mulligans now and then. The more serious symptoms, from my view, include things like, not being aware of the mistakes or the lapses, right? So like, say, asking a question and then repeating it a second time, well, maybe you get a mulligan for that. And then a third time or fourth time, it starts to get a little more worrisome, or like, telling someone a story and then telling it again. It's the same story kind of unchanged. And the person seems unaware that they've told that story, right? That's maybe a little bit more concerning. I think the kind of lapses that lead to kind of, socially awkward or embarrassing moments, because we're social animals and we're most people kind of fearful of making mistakes in a social context like that. So it's kind of more serious when people are making mistakes because people try hard to avoid them. But you could say the same, I guess, about like a fiscal mistake or like at work or something, right? Something that's led to some sort of financial loss or awkward situation fiscally or at work might be considered by me maybe a little bit more concerning, right? And needs to be looked into. And again, some kind of loss of, loss of a kind of financial cost, a mistake or a slip that's been made is more concerning than one of these kind of high mistakes that's kind of picked up and then moved on. When it's coupled with changes in kind of personnel behavior too, that's something that I worry a little bit as well. And some of the research we've done at the University of Calgary with my colleague Xavier Ismail has shown this, right? When you have a combination of memory change and a personality change. By personality change, I mean, it's something that's different about them. So it's not just the way they've always been, and it's persisting. It's not just a bad day, but something you see recurring. The combination of those two things is something that is worrisome. And then hallucinations or delusions. Delusions are these kind of like funny fixed ideas you can't shake people off of. That's kind of unusual for anyone. Like that's sort of outside the typical like human experience. So that would be something that would be appropriate to ask your doctor about. So hopefully that gives you kind of some sense. And then, you know, sometimes one of the challenges too is that the person with the symptoms may be sometimes the last person to recognize it, right? There's the dementia can affect the brain that affects what we call people's insights. You know, that's what how we talk about in the medical chart. You know, the insights, the awareness of what you're doing and how it affects people around you. And sometimes that's kind of lost. So it may be that someone's spouse or their loved one is more the one to notice the symptoms than the person themselves, right? And it can be like a difficult situation or a tough conversation, as you can imagine, to have to talk about it with your loved one. Like, I think maybe there's been some changes. I think we should talk with the doctor about it, right? It takes a little bit of, depending on the relationship, it's not always easy to have these conversations. So I have to acknowledge that, right? But it is, I think, appropriate to talk about it with that person, and then, you know, recommend that they talk about it with their doctor. One thing I'd like to recommend is if you do want your loved one to see the doctor about their memory, you know, go to the visit with the person, right? Because I think sometimes if there's lack of insight in the severity of the symptoms, you know, the person goes to the visit and they come back and they say, oh, the doctor said it was fine. But, you know, sometimes it's good practice whenever anyone goes to the doctor for any reason to have someone there to help you listen, understand, and remember, because it's hard to take all that in with or without, you know, a memory or a potential cognitive problem. It's even harder if you have a cognitive problem. So to be there both to support the person, but also to help understand and hear directly from the doctor, it's good to have both people come. So if we get referred someone from a family doctor to say this is a challenging case, and I want your help to know whether there's really a cognitive problem or not, we will ask them to bring someone with them so that we can get some support. You know, as I tell people, if you may be forgetting things, you might forget what you forgot, right? So that's why it's helpful for me to have someone who remembers what you forgot, right? So that helps us make the best possible diagnosis. Okay, now why would I want to be diagnosed? I think that's a fair question to ask too, right? I mean, I think you're all here because you want information and to address these kind of problems and to talk about it openly, but to be completely frank, there's a stigma around like acknowledging that there are cognitive limitations, and there's still stigma around some of these diagnoses that we give people. So a lot of people, you know, are understandably, you know, kind of afraid of getting a diagnosis, or there's some nihilism around it too. And this is not just for patients, I think some doctors too. They're like, well, we don't have a cure for Alzheimer's yet, so why should I label somebody with this? Like, why would I need to look into it? But I think we have to respect each person and the stage they're at and what they want to know and not to know. So that's one of the principles of making early diagnosis. But I think there are, for those who are ready, you know, there's lots of good reasons to understand whether they have a diagnosis or not, right? And that can include, it can include validating and understanding the cause of symptoms that have been the source of stress and uncertainty, right? Even if we're certain that it's the thing that you hoped it wasn't, you know, knowing that certainty can sometimes help you understand and cope. It can help people and their loved ones to make plans for the future, understanding, you know, what's happening and what the future might hold. It allows the doctor to look for potentially treatable or, you know, causes or things we can do to optimize function, you know, to help people function better, right? So, and we'll go into some of the tests that a doctor would order in a moment, but often we can give advice that can help maintain or improve people's memory. There are medications to enhance memory, right? They're not a cure, you know, but they can help some people. And I've seen some people have really good responses that seem to maintain their memory for years. And if you don't get a diagnosis, we won't know whether one of these medications might benefit you. It can help get access to community resources and knowledge, like to the Alzheimer's Society, but also for programs that offer health services and private programs. It can allow one to take steps to ensure like safety and like safe living. in the community and in the home. For those that want to make a contribution, it could potentially offer opportunities to participate in research to identify the causes and look for cures. Most of the new, drugs and other things we're testing for dementia are, people feel that if they can be applied at an earlier stage, before too much changes have happened in the brain, it may be more effective than applying at a later stage, right? So that's the rationale for that involvement in the research. So what and if you go see the doctor, then what would the doctor do? They'd ask about the symptoms of the different kinds. There will probably be some sort of cognitive evaluation done. There's a variety, and the variety is kind of expanding a little bit. The most commonly used ones have been a test called the full-speed mini mental status examination. It takes about 5 or 10 minutes. And then there's a slightly longer but more version that's more sensitive to early changes called the Montreal Cognitive Assessment, or MoCA. There are other alternatives that a doctor might use as well, and these involve, doing some cognitive tasks, and then from that one can see whether there's evidence in the office where you can reproduce some of these symptoms and understand better the severity by having them do like a standardized test where we know kind of the range of scores that different people have. The doctor would do blood tests to look for some treatable causes of memory problems that could include hormone problems like with the thyroid hormone, for instance, vitamins like vitamin B12, other chemistries in the blood that if they get out of whack cause confusion or difficulty with concentration. They'd ask about potentially stress or mood or sleep or medications or other stresses that might be interfering with cognition. And probably in most cases, if they identify concern on that cognitive screen, in most cases a brain scan of some kind would be needed as well, like a CAT scan or an MRI. CAT scans and MRIs don't show Alzheimer's, but they show some of the other things that could cause cognitive decline, like a brain tumor or a stroke, for instance. So these need to be looked at. People ask me, is there a test for Alzheimer's? We don't yet have a cheap, kind of a cost-effective, non-invasive, widely accessible test that tells us who has those plaques and tangles in the brain. There are some specialty tests we use sometimes when the diagnosis is not clear, and that can include another type of scan called a PET scan. And in that scan, there's an injection of a tracer, and the tracer sticks to different proteins or molecules in the brain, and the brain lights up where the tracer sticks behind. The most common one we use is called FDG PET, which is FDG is a type of glucose, like sugar. Sugar is the brain's fuel. So providing this labeled sugar, we can calculate the rate at which the brain uses its fuel, which is called metabolism. If the brain's not working hard enough, then metabolism is low. And we can look at the pattern of metabolism across the brain in this sample image here. I don't know. Like this kind of bright color is normal. You see where it's kind of darker green on both sides. That's where the metabolism is lower, right? So that's a case where there was dementia in this case. And then we look at the pattern of metabolism for what the cause was. In this case, we inferred the cause was Alzheimer's disease. There are other types of PET scans where you inject different kinds of tracers to stick to different things. So people made tracers that actually stick to the plaques. So you can inject a tracer where the plaques will light up. Or people are beginning to develop tracers for the tangles as well. So you inject the tracer where the tangles light up. But these scans are very, they're still mostly in the research domain. They are, most of them are not approved by Health Canada for use in Canada. They're very expensive. Alberta's Health Services is not offering these scans in Calgary. Even patients of mine that have gone to Mayo Clinic, they usually don't come back with one of these scans either. So even in the United States, where a lot of very expensive health interventions are done, some argue about the cost effectiveness of some of them. They're not usually using those kind of scans either. They're mostly used for research purposes. But if they improve in their accuracy and their affordability, it might be something we can do in the future. We can look for the proteins that make up the plaques and tangles by testing the spinal fluid as well. So that's something that we do sometimes, although it's really only when we have like a kind of a dilemma or a diagnostic question that I feel is important to answer. To get the spinal fluid, you do a test called a lumbar puncture, which is shown over here. So the person curls up in a ball and you put a needle in the back, kind of in between the blocks of the spine. And it's kind of similar to what women get or many women when they have a child, called an epidural. In that case, they put some pain medicine in and freezing medicine in. In this case, we go a bit farther, we take some of the spinal fluid out. And the fluid is very useful because it reflects the actual chemistry in the brain. Like this is a fluid that circulates around and through the brain. So we can see the proteins that make up the plaques and the tangles by testing the fluid. I do these tests all the time. To me, it's kind of like an outpatient, dental procedure. So it's not an operation. You don't have to admit to the hospital to do it. It's like with the dead, we freeze the area, we put the needle, we take the fluid out. It is an invasive test though. Like it's more than just having a blood test, right? So we only want to use it where we feel the discomfort and the risk of the test, which are small still, but we want to make sure that we use it where we feel the information to be gained is necessary. So it's not typically a test we do in someone with a routine diagnosis of Alzheimer's disease. It's usually when we're ruling out kind of rarer what are called autoimmune diseases or vasculitis or other inflammatory conditions of the brain. So it's not an often, but it can be done. There's a lot of work in the research realm now on blood tests for Alzheimer's. This may be the actual practical way to do a test to see who has plaques and tangles in the brain when they have memory symptoms without an expensive scan, like a PET scan, like X-rays. PET scans involve some exposure to radiation too, so we want to minimize the number of scans that we do in people. With technologies like mass spectroscopy and single molecule assays, we're able to test increasingly like tiny fractions of concentrations of proteins in the blood. And it turns out that a small number of these proteins that make up the plaques and tangles kind of leak out into the blood, like too small to see with regular tests, but with these advanced tests, people are starting to be able to detect them. So there's a possibility, none of them are really sort of ready for commercial use. So I'm not able to order them. I don't use them in the clinic, but in the future, this might be something that we can do in the clinic to look for Alzheimer's. Right now, making the diagnosis of Alzheimer's, in most cases, it involves the blood work for other conditions, doing a scan to rule out strokes, tumors, a condition called hydrocephalus and others, and then looking at the pattern of problems, and from that we can, with pretty good accuracy, make a diagnosis. But most of the tests we're doing are to exclude things that aren't Alzheimer's. They're not kind of ruling in Alzheimer's. And then, receiving the diagnosis, best practices around disclosing a diagnosis would include exploring the person's perspective. What's their perspective on these memory changes? Is Alzheimer's something they're worried about or not? How much do they want to know about the diagnosis too? I think we want to, I think there are good reasons to know the diagnosis and they might explain them, but I want to respect people's autonomy and wishes not to hear about the diagnosis and focus on other things. To include family members, for support and to help, help keep a record of what the doctor said, like translate the doctor, what the doctor said into the daily life without losing it. To have a focus on person's well-being, rather than a focus on their limitations, and to help people when they're ready, to think about planning for the future. So that could mean that a doctor might talk about having documents to indicate, for example, who should take care of one's finances, right? If at a later stage they needed help with the finances. So that's done through a legal document called an indirect power of attorney. There's a way to give future advice about your medical care through something called an advanced medical directive and making a will. Now, these are things that I've done, and everybody should probably do it, but a lot of people wait until it's later in life, or maybe they have an illness or a medical problem. So we want to, advise people to do things in advance. It's not easy hearing about a diagnosis like this, right? Responses include sadness, grief, anxiety, denial, even bargaining, or maybe it's something else. Why don't we test for this and that? This kind of thing. So it's certainly a difficult time for many people. There's a need for support by having information and understanding. I put down a website there that I think is one good website. It's a Canadian website from Health and Health Sciences, developed through government funding to their health organization. That includes, a list. It's more for, I guess, people with more established diagnosis, not early diagnosis, but it goes over some of the symptoms and what they mean, and as a care partner, how you might respond to them. People often ask about the future in terms of life expectancy. There's a huge variation, I guess, to start out with. But an average life expectancy from diagnosis of Alzheimer's specifically would be something like 7 to 10 years. But we see people who live longer and people who live shorter. Like, there's a lot of variety around that. We want to give information on support and resources, right? And the Alzheimer's Society is one of the things that I rely on to provide information and support. So they have a program called the First Link program, where I can send a referral to the Alzheimer's Society and say, hey, I've made a diagnosis in my patient. They've given me permission for me to contact you. So I'm giving you their number, and then someone from the Alzheimer's Society can follow up and talk about the programs that they have that might be helpful. And you may hear about some more of those tonight, for example. Making plans for the future, talk about some of the principles there. These are some principles of the management, from a physician's perspective, how I divide things in terms of helping people cope with an early diagnosis. A lot of it is that, the physician's part of the team, and our main role is to test to make a diagnosis. We prescribe medications. And we usually play a major role in the leadership of the team too, right? At the end of the day, we want to be in charge and say, if there's things that are needed, the buck stops here, sort of thing. But there are other people who might be part of the team to help someone with dementia too. Other health professionals might include a social worker who might provide advice and counseling on things like access to community resources, things like financial planning, because there are things like a disability tax credit, for example, that people may not be aware of, that they should need information on how to apply for that. Our team, we rely on a social worker to help provide that information and counseling and support. Sometimes when we want to map out the cognitive symptoms more precisely, we might refer to a type of specialist called a neuropsychologist, who does more extensive neuropsychological testing, particularly if we're not, we're not sure what the cause might be, or even if there's a problem or there's not a problem. Sometimes we can refer to neuropsychologists for more testing. A nurse practitioner may be part of the care model in many clinics. Sometimes there may be a pharmacist. So there's a whole group of health professionals that may be engaged and involved in the care. My role is as a specialist consultant physician. So most diagnoses are disclosed by family physicians and care is provided by family physicians, but there are challenging cases where there are unusual symptoms or potentially unusual causes, or physicians may be not sure whether there is early Alzheimer's disease or not, and so that might prompt a referral from the family physician to our clinic, which is staffed by neurologists and geriatric psychiatrists where we do assessments. So that's my role in the team. The other principles are think about advanced care planning. There are medications that may be useful. I'll describe those briefly in a moment. We want to think about safety. We have to monitor and talk about driving. This is one of the difficult things because with a progressive condition like Alzheimer's, there will likely be a time when we have to make a medical recommendation for people to refrain from driving. It comes with some difficulties, right, in being able to transport in terms of the person's autonomy, so we want to support them and give them advice on alternatives on how to get around if they're at a stage where driving is no longer an option. We want to offer community supports that includes, things like day programs or respite. And we want to also focus on just general health, including vascular risk. There's a lot of the risk factors for dementia and Alzheimer's overlap with the risk factors for heart attack and stroke. These include things like high blood pressure, diabetes, smoking, high cholesterol level, being above an healthy weight. These things have been linked with heart attack, but also dementia risk. We want to look for those in everybody and optimize those if that has not been done already. The medications that are approved by Health Canada for use for, and they're specifically indicated either for Alzheimer's disease or when someone with Parkinson's disease has dementia, there's 3 medications called cholinesterase inhibitors. These medications increase the levels of a brain chemical called acetylcholine, which is a chemical the brain cells use to communicate with each other. So it facilitates better brain communication. It doesn't prevent the cells, like the underlying problems of the cells being sick or being lost eventually, but it helps the ones that are there sort of communicate better. And in some people it can help facilitate better cognition and reduce stress and anxiety and frustration. And then there's another pill in the right column that's more effective for more moderate to advanced stages called memantine. That's the chemical name. It's sold under a brand name called Abixa. In contrast to the other ones, the memantine it's approved by Health Canada for treatment of Alzheimer's disease, but it's not on the formulary for Alberta Seniors Blue Cross. They looked at it and they made a decision based on not just the effectiveness, but also the cost, and said the effectiveness doesn't justify the cost. It's overall kind of not as effective as the other ones, the cholinesterase inhibitors. I've had some of my patients, we have a discussion about it. Some of them want to try it because there's a limited number of things that we have to try. And I would say some people find it helps them, but others don't. And many of them, to pay for it, you have to pay out of pocket or have some sort of supplemental insurance. So hearing that is not a cure. Some people prefer to focus their energies and monies on other things rather than more pills, and that's okay too. But we have a discussion and reach kind of a patient-centered decision about that. Okay, so I'll just kind of summarize a bit about what we've talked about, and then I'm happy to take some questions. So, one thing I want to acknowledge, occasional lapses in memory and concentration are normal, part of the human condition. That makes it hard sometimes to know when to worry about, changes in brain thinking. If you are worried, I encourage you to just kind of face it, right, and talk with others about it. Avoid the stigma. Talk to your family doctor if it's your loved one, although it's a difficult conversation. I think it's okay to talk with them about it, encourage them to see the doctor, go to the doctor with them to help the doctor get a full history and assessment and to help support your loved one. Because people may not always be aware of their symptoms. And then, getting a diagnosis, these are scary problems to face. But I think the reasons to get a diagnosis, including getting support, getting help, getting the peace of mind that comes with understanding and knowing, having access to these medications if it's appropriate for your specific medical condition at an early time rather than at a later time. And the Alzheimer's Society is one of the places where people can look to for help and support, right? There is this during this time where we made a diagnosis and we're thinking about what's next and helping people start their journey of living with these conditions. So I'll thank you very much, and I guess I'll turn it back over to Rachel. Or okay, thank you.